So as Dan said, and I'm kind of a little disappointed, Dan, that you didn't show up in zombie makeup. I was expecting you to like be blah coming towards us, wanting to eat brains. But this is not an April Fool's Day joke. This is after noon hour, so April Fool's is officially over. So we're going to be talking about some really serious things. And specifically, we're going to be talking about zombie ideas about emergency department crowding. So I know some people might be going, hey, what the heck is a zombie idea? Well, it was coined and defined by an economist named Paul Krugman in 2013 in a New York Times article. And he defined a zombie idea as one that is a view that's been thoroughly refuted by mountains of empirical evidence, but nonetheless refuses to die, being continually reanimated by our deep held beliefs. So, a zombie idea in emergency medicine is an idea that just won't die despite decades of evidence. And every time we think we have killed this idea, this zombie idea of emergency medicine, it just comes back alive again. And so this idea is going to focus specifically on crowding. And so I want to define crowding. And crowding has been defined by the Canadian Association of Emergency Physicians, as well as the American College of Emergency Physicians. They're very similar. CAPE says crowding is a situation where the demand for emergency services exceeds the ability of an emergency department to provide quality care within appropriate timeframes. And ACEP says ED crowding occurs when the identified needs for emergency services exceeds the available resources for patients' care in the ED, hospital, or both. So what is this zombie idea? Well, one of the zombie ideas in emergency medicine regarding crowding is that it's the non-urgent patients who are responsible for crowding. If we could just get all these non-urgent patients, if they weren't in the emergency department, then emergency department crowding would just all go away. Well, this is a zombie idea. And to drill down a little farther, a zombie idea is that if you divert these non-urgent patients, and typically through blaming, shaming, posting wait times to encourage them not to come, telling them to go somewhere else, like, why aren't you in your primary care clinician's office? Why didn't you use a walk-in clinic? Did you know pharmacists in many jurisdictions can treat urinary tract infections? How about telemedicine? All of these things. They think if we divert patients from the emergency department, crowding will be solved. This is something I like to call the diversion danger. Diverting non-urgent patients from the ED will end up missing some sick patients. I know my colleague will confirm that patients do not arrive to the emergency department with a label on the forehead saying, hey, this is heartburn, or no, this is a heart attack. They arrive to the emergency department with symptoms like, I've got some indigestion, I've got a little pain or pressure in my chest, I feel a little short of breath. It would be so much easier if patients would just come in with their diagnosis on their forehead, but they don't. And if you divert these non-urgent patients from the ED, the emergency department will still be crowded. It doesn't fix the crowding problem. It doesn't address the underlying major problem that is responsible for crowding in the ED, i.e., it's ineffective. It doesn't work. And on top of all of that, it's not patient-centered. The patient declares whether it's an emergency or not. Dr. Dingwall and I have years of experience between the two of us, and so what we think might be an emergency may not be what the patient thinks is an emergency. And what the patient thinks is an emergency, that, let's say, sore throat, they think it's really, really important. And so they think it's an emergency. And that's why we're there in the emergency department to assess people to make sure that that sore throat isn't an emergency, isn't one of these terrible medical conditions. And so, to put a very fine point on this zombie idea, diverting or fast tracking someone with a sore throat, like putting them in what we call the green zone or the RAS, the rapid assessment zone, or having a nurse practitioner, a PA, or a pharmacist see these patients, does not get that elderly patient who has fallen and broken their hip, who is stuck in the emergency department with no inpatient bed. It doesn't get that patient a bed anytime sooner in the hospital. And so what we have in the emergency department is something called an emergency department compartment syndrome. The ED is the only part of the healthcare system that cannot and will not say no to people. All other aspects of the healthcare system can decline to see a patient. The ED is the light in the house of medicine that is always on for anyone, at any time, for anything. However, it's become a place for everyone, every time, for everything. Dr. Dingwall and I have become availabilists. We're available. And when you can't see your primary care physician, the surgeon, the psychiatrist, the other specialist, just go to the ED. They'll take care of it. And these issues, even a prescription renewal for your blood pressure medicine, becomes an emergency due to lack of access to care. The front door of the ED is always open. Well, not in some rural places now, but the back door, the inpatient unit, the home care services, the mental health care services, the long-term care services, these are often closed. So this overcrowding, it's not an emergency department problem, but the problem shows up in the emergency department. But it's a system problem. And so we need system solutions. And when we look at the problem, we have a lack of inpatient beds. These are medical beds, surgical beds, intensive care unit beds, mental health beds, long-term care facility stuff. We also have a problem with a lack of access to primary care. We don't have enough family physicians. We don't have enough access to nurse practitioners or pediatricians. And there's a lack of access to home care, physiotherapy, occupational therapy, wound care, VON, PSWs, all of these things. That is a system problem that's showing up in the emergency department. But there's also a lack of access to advanced imaging, like ultrasounds, CAT scans, MRIs. And so people are often told to come to the emergency department looking for faster access to these diagnostic imaging tests. And in addition, we have pharmacists and EMS providers who have restrictions on what they can do. And so it's not allowing them to participate fully in the system and practice up to the level of their training and more be better at addressing patients' needs. Now, the main reason, here we go. The main reason for ED crowding is often described as a lack of beds. This is a short form, and it's what like a saying that you can say, oh, well, we don't have any beds. This is what I like to call the furniture fallacy. Canada has a below average number of beds per 1,000 people and the highest occupancy rate of acute care beds in OECD countries. So it's not a lack of beds. We have furniture. We can buy beds too. But what we have is a lack of staff. And specifically what I'm talking about is we have a lack of nurses and nursing staff to take care of admitted patients. So it's not a furniture problem, it's a staffing problem. And because we don't have the staff to take care of patients on the inpatient side, patients get warehoused on the emergency department side, waiting for hours to days for a bed in the hospital. And this is not just some inconvenience. And I think Dan mentioned that in his introduction. This can be deadly. So you can have delays which are associated with increased mortality. If you hold a patient who's over 75 overnight in the hospital, there was a study published recently in the Journal of American Medical Association looking at almost 1,600 patients, and they found a 5% absolute increase in mortality associated with being boarded or staying in an emergency department overnight instead of getting an inpatient bed. And so this is a reminder. This is a reminder that this can have deadly consequences. And so what do we need? And look at, I use the short form. We need more beds. And what I mean by that is we need more staff to staff the beds. And this is not one study. We have known about delays associated with badness. And I've just put 4 studies up here going back almost 15 years. So we've known for decades that this is a problem. Delays, boarding patients, holding patients in the emergency department can be associated with badness. But, I don't want to focus so much on the badness, but what are we going to do for solutions? I'd like to focus on solutions. I'm more interested in solutions than I am with blaming. And so some of the zombie solutions that don't have high quality, good evidence of efficacy, one of them is triage people away. So you divert people. They come to the emergency department and you triage them away. Studies have looked at this where patients come to the emergency department and they're redirected, and there's really mixed results. And there is that risk, which we talked about earlier, of missing that patient who has heartburn but really has a heart attack. And then people have tried to implement these fast tracks in the emergency department. But again, seeing non-urgent patients faster, like that sore throat, like that urinary tract infection, doesn't get the patient with a hip fracture a bed earlier. And if that patient is over the age of 75 and held over in the emergency department for one night, you've just given them an increase of a 1 in 20 chance of dying associated with that delay. And then, of course, other solutions that have been tried, which I would refer to as a zombie solution, is to put a doctor in the triage department. Again, this has mixed results. It can increase length of stay in the emergency department. And Kay and I both work in rural emergency departments. And so rural emergency departments are struggling to have one doctor in the department. We don't have the luxury of having 2 doctors in the department. So how can you have the one doctor sitting up at triage while at the same time they're taking care of patients in the emergency department? So this is not going to work in rural settings. And then one final thing that has been tried that I think is a zombie solution is we'll just make the emergency department bigger. Yeah, let's just add chairs. Let's just expand the waiting room. Let's just make the inner part of the emergency department bigger so we move the waiting room into the actual department. We don't add staff usually. We don't add a number of emergency physicians to work it. We just increase the tank. And I like to use the analogy of the 401. I assume some people here have driven on the 401, and some people are old enough to have driven on the 401 30 years ago when, let's say, they had 8 lanes going into Toronto. And what have they done? They've added lanes, and they keep adding lanes. And now they're up to something like 16 lanes going into Toronto. Has the traffic gotten better or worse? And in a rural emergency department, if we add lanes, we make our department bigger, maybe we can get the wait times down a little bit. But what that tends to do is encourage people from the urban areas, and I see this in Strathroy. Patients say, oh, well, it's an 8-hour wait at London Health Science Centre, but it's only a 3 or 4-hour wait in Strathroy. And I understand. I think I'll go to Strathroy to get the care I need. But if you make that care faster, quicker, more accessible, you're going to encourage more people to come to the rural facilities who won't have additional resources. And at the end of the day, making that ED bigger and trying to assess those fast track patients quicker, you'll just end up with a crowded highway and the 401 will just get busier. So, what should we do? What should we do to address this problem? Well, first of all, don't let the zombie idea dictate policy. We should use evidence based solutions to ED crowding. And those solutions will have to come from those primary care facilities, from those rural hospitals, those emergency departments around Ontario, where we're talking to mainly people, is that we need to find evidence-based solutions that work in our local centers to address this crowding situation. But you might be wondering, who keeps these zombie ideas alive? Well, I would say there's probably three main sources. One is politicians. Like many other people, they do want to see this solution fixed. We have common ground with them. They care about patients too. But their timeline may be an election cycle and not as long as it takes to fix these solutions or fix these problems. And so they tend to use zombie ideas that may look like a quick fix rather than addressing the underlying problem. We also have administrators who, again, want patients to get the best care, timely care, the right care by the right provider. Their heart is in the right place. Unfortunately, we've put in these control systems for administrators that reward meeting metrics for non-urgent patients. And so you can understand why their focus might be more towards, listen, we've got a lot of people, it's backing up in the emergency department, the wait times are going up, and we're losing funding or not getting our funding bonuses to help support our emergency department. And so we've got to do something about the non-urgent patients. And then finally, I would say the media plays a role at times in highlighting the non-urgent use that tends to shame and blame patients for using an emergency department for their non-emergency problem. And again, I'm more interested in looking at real solutions and less interested in blaming patients for accessing care. So what do we do? Well, I would say stop feeding these zombie myths. Overcrowding is an emergency department issue? No, it's a healthcare system problem. Non-urgent patients are the cause? No. Non-urgent patients take little time and resources. They are not the major part of the crowding problem. And then finally, what's the harm? People have to wait a little longer. They might have to spend a night in the emergency department. At least they're in a hospital. No. Boarding of patients is associated with increased mortality. It can be deadly. And so the best way to finally kill a zombie idea is stop believing in it and fix the system.